one type of lenses about Rayner, and this is by Dr. Ramesh. He's specialized in laser eye surgery, cataract and lens replacement surgery at both London Flagship Clinic and Moorfield Private Eye Hospital, London. So we'll have a very interesting session with and talks by Dr. Ramesh. Then we can have a discussion after that. So dear colleagues, I think we can now mute all ourselves and give Dr. Ramesh to enjoy us with his talk. Please, Dr. Ramesh.
Thank you, Mohammed, and thank you for inviting me to speak to you all. Let me just get my presentation on screen so I can share that with you. Here we go. So, actually, let me just get back to the beginning of this. So I'm really just going to talk for about 15, 20 minutes on my experience with the Rayner Ray 1 EMV lens, which is a new category of lens that's emerged in the last year or two. I'm a consultant at Moorfields Eye Hospital and also at OCL Vision in London, and used to come out to Dubai every couple of months to see corneal graft patients at Moorfields Dubai, which is a lot of fun, but that's stopped recently. So in case you don't know much about this Rayner EMV lens, it's a new type of lens which has entered the market together with some other lenses from other companies that are similar. And the EMV lens is essentially a monofocal lens, but it's a monofocal lens with enhanced depth of focus and enhanced range. So essentially aspheric on the anterior surface, and then has some controlled positive spherical aberration to extend the depth of field. And we know from multiple optical studies and research that either positive or negative spherical aberration can increase depth of field and improve your closer vision. So the principle here is really to play around with that, and we've been doing that in the past with laser eye surgeries for some time, but this is really one of the first of the kind of newer generations to really do that. So the idea here is that the EMV lens as a monofocal will maintain the excellent kind of distance visual acuity and quality of vision you get with a standard monofocal, but give the patient increased range of vision and increase their intermediate vision. And patients these days spend a lot of time looking at iPads, iPhones, and other sort of digital devices in that intermediate range, and that's become a sort of important range to see at. And the lens is designed to give about 1.25 diopters of extended range of vision from one eye if it's set for emmetropia. It's quite forgiving because if you look at the optics and the defocus curve, if you don't hit your emmetropic target, patients still maintain good distance vision up to plus or minus 0.75 to 1 diopter. So it complements the eye's natural positive spherical aberration, and it's less pupil dependent and all those good things. But essentially, it's trying to create a smoother blend in the two eyes, and this lens is really designed for use with a monovision type setup with the non-dominant eye targeted for about a -1. And monovision isn't anything new. We've been doing that for decades really, and we know it works relatively well. But this is really carrying on from the kind of thing that Zeiss have been doing with Presbeyond, and that's to use spherical aberration to try and get rid of that kind of blur zone between distance and near, and give a smoother range of focus from distance to near intermediate when you're using a monovision type of setup between the two eyes. So that's really where these lens designs like the EMV are taking us. And the other lenses on the market that are similar are the Johnson & Johnson Technis Eyehance lens, and the Alcon Vivity lens, which fall into that sort of category, which are kind of trying to improve intermediate vision whilst maintaining the qualities of a monofocal. So, we've been using this since probably July 2020 at OCL Vision, and we looked at some of our results. And this is not just me operating, this is 3 surgeons. And we've used it in different ways. We've used it either as in a single eye as an emmetropic target, in both eyes as an emmetropic target, or as sort of suggested by the company with a kind of monovision type target. So we'll just look at those 3 groups and look at our results. And so in all eyes which were just targeted for emmetropia, distance vision is excellent with this lens. 84% of patients seeing logMAR 0, 30% minus 0.1. There's no complaints about their distance vision, which we wouldn't expect. We expect it to perform like a monofocal, and we're targeting emmetropia in this group. What's unusual and beneficial really is what they get at intermediate. And so 57% of patients are able to see N8 at an intermediate distance when targeted for emmetropia. Some of them even N6, and a very few N5. Now that's unusual because you wouldn't expect that really with the amount of near focal add in this thing. When we look at near vision, so that was for intermediate. When we look at near vision, again, they're maintaining pretty good near visual acuity, even with an emmetropic target with the lens. So that's in one eye. When we look at those patients and any issues they had, individual eye problems, one patient had some negative dysphotopsia, not halos. This was more kind of dark arc of typical negative dysphotopsia in the periphery of the vision. One patient described some starburst type effects, which were indistinct. We had a patient with postoperative uveitis, some steroid responders, and a patient with cystoid edema. So moving on to the bilateral implantations, and again, this is bilateral emmetropic target, not monovision. And again, they get good distance vision, and there wasn't any compromise to what we were expecting. logMAR 0 in 100% of patients, some better. So looking at their intermediate vision, binocularly, as you'd expect, they could see a bit better, and 100% were N8, and 70% were able to see N6. So, that's a pretty good range of vision for a monofocal enhanced lens that doesn't have some of the negatives of the trifocals that we're using. Unaided near vision in these patients who had bilateral implantation aimed at emmetropia, again, 100% N8, N6 were, some of them were able to see, and a few even N5. So again, better than expected compared to a standard monofocal. So even if you're using the lens, as a premium monofocal, and one of the conversations that I find awkward, or used to find awkward with patients, is when you see a private patient and they're paying extra for what they consider a premium monofocal. Some of the kind of savvier ones will ask you, well, what's premium about this monofocal? And it's difficult to really tell them what's premium about a monofocal that doesn't give them anything but distance vision. And the thing with the EMV and these sort of enhanced monofocal lenses is that it does give them something more than your standard kind of monofocal lens that might be covered by their insurer, or they would expect to have if they were having it done in the public health service. So that's really the patients who had emmetropia targeted with this EMV lens. We then looked at more patients where we actually targeted monovision. And this was sort of aiming for about -1 to 125. And there were about 24 eyes in this group. So again, unaided distance vision, excellent, as expected. And you'd get this with a standard monovision with a monofocal lens, not even. But what's really impressive is that their intermediate vision is N6 in 100% of cases, with about a diopter of offset between the two eyes. 50% of them seeing N5. And if you look at near vision there, again, N6 in 100%. And so, very nice outcomes in terms of the intermediate and near vision when you actually are aiming for monovision, and seemingly a good range of vision there. So when we looked at what our kind of final spherical refraction was in the non-dominant eye, it was around about -1.5 plus or minus 0.42. So, maybe they were getting slightly higher levels of myopia than the -1 that the manufacturer actually suggests that we should use. So, we've continued using this lens, and as I've become more confident with it, I'm more confident in recommending it to patients who do have a desire to be as glasses independent as possible, but might be nervous about some of the negative effects of diffractive intraocular lenses like trifocals with halos and things like that, or driving at night. If there's a patient who really likes reading a lot rather than looking at their Kindle or iPad, I may have a kind of discussion more about whether they're better suited to a trifocal, which might give more guaranteed near vision. But I think really the EMV lens as one of the kind of new lenses in this category is a true monofocal plus technology, and I don't think we had that available to us to offer that to our patients before, and where we can really say, look, this lens is actually giving you something more than a standard monofocal can. And so distance vision, as we've seen, the properties of the lens are typical of a monofocal. There were really very few patients, at all, who complained of any halos or glare. There were no issues with driving at night from the patients that I've seen. And so far, we haven't had to explant any of these lenses. None of the typical symptoms you hear when you place trifocal lenses into people's eyes. Now, I use a lot of trifocals, and probably more trifocals than I use than the EMV. But all of those patients do describe halos when they drive, and they're just they're willing to accept it for what they think is better vision. But I think there is probably a move towards looking more at the quality of patients' vision over the kind of quantity of vision, and that's where this new group of lenses come in. So in terms of intermediate vision, they function well, and that's probably fitting in with modern lifestyles and that intermediate zone where people need to see well. Driving, for instance, seeing your dashboard would be much clearer with this compared to a standard monofocal. The defocus curve is forgiving, so if you don't hit your emmetropic target, again, if you forget about trying to enhance the range of vision, but you just want to give your cataract patient who wants a monofocal a better guarantee of good vision, just in case you don't hit your emmetropic target, these new generation lenses have a more forgiving defocus curve that can help with that. Micro monovision seems to be the way to go with this, to really boost the near vision, and in patients that seem to tolerate that in the clinic, we'll just do that as a standard thing now. And I think really that patients, if this category of lenses really takes off, probably won't need to compromise that much in terms of their quality of vision to try and improve their range of vision. And I think if you speak to ophthalmologists implanting lenses, most of them would be slightly anxious, being kind of type A personalities, about having a trifocal lens. And I'm not sure how many ophthalmologists, when they come to their own cataract surgery, would have a trifocal lens. But I think this sort of technology, the enhanced monofocal technology, really is something that is you probably would have without feeling nervous about it, because of the quality of vision you're getting. So it's a useful lens. We've enjoyed using it. It's easy to use. It comes in Rayner's usual kind of injector, which is easier for the nurses to prepare. And so far, we haven't had any issues with it, and we're just carrying on implanting them, and our patients seem to be happy. So thanks for letting me present that to you. Of course, none of that data came without help from some other people preparing it. So thank you to them. And do you have any questions or discussion around this?
Thank you very much, Dr. Ramesh, for this an excellent presentation and new introduction for this new technology. Not say technology, but something, I mean, new in the market. I think there will be a lot of question about this one, but I have one question in my mind. In those cases, you mentioned sometimes maybe the most important target is to target the emmetropic. In case you didn't achieve the emmetropic, and how is it will be the management of these situations? How do you face and how do you manage?
So, Mohammed, the thing with this lens is that if you look at the defocus curve, it's more forgiving for distance vision. So say you don't hit emmetropia and you're within plus or minus 0.75 to 1 diopter, they still maintain good distance vision. So, you know, it's pretty unlikely you've got to enhance them. That's very different to a trifocal lens where, you know, if you don't hit emmetropia or you haven't dealt with their astigmatism, they're very likely to have poor vision. And you do have to enhance them. So enhancement, I mean, we haven't enhanced any of our patients because we haven't had to. And, you know, they, you know, probably it's a sort of group of patients that are more forgiving as well, because they haven't been obsessed about being, you know, totally guaranteed glasses free, which is probably where the trifocal type of patients fall into. So, you know, there are more forgiving bunch of patients, but just because of the optics, it's a forgiving lens and we haven't had to enhance any of them. But if I had to, I would just laser them, you know, that's.
Okay, I mean, Ramesh, you know, sometimes you are going to face some patients, they are highly professionals. I mean, like maybe a doctor ophthalmologist, maybe sometimes. So it's, and you didn't, in this kind of, I mean, patients, they are looking for really emmetropic, and they are very precise about that. So did you face something like that?
No, I haven't faced that yet. But if I was to, you know, I would deal with that in the same way that I deal with a trifocal patient or any other patient where we haven't hit the target and they've got a suboptimal result that needs refraction. And that would be that, you know, 3 months down the line, I do a LASIK on them and refine the outcome.
Is there any correlation between if you didn't hit the emmetropic and the intermediate, I mean, corrections? If you didn't hit the emmetropics, so there will be an effect on the intermediate that you are going to get by the lens?
There will be an effect depending on which way you've gone. You know, if you've become more plus, then you're going to get less of an intermediate vision. So, you know, that will inevitably have an effect on how good your intermediate and near is. If you've got more minus, obviously, you're going to get better intermediate and near vision. So, you know, there is a correlation with that.
Okay, is there any comment?
Actually,
Yes,
sorry, one thing to say is that actually one of the things you find with this lens is that when you aim for emmetropia, you tend to come out slightly minus.
Okay.
With the lens. Okay. And actually the Rayner up to about 0.5. And so Rayner specifically tell you not to make any adjustments to your calculation and just to go for emmetropia, even though you know you're going to come out slightly minus. Okay, and that probably helps a little bit with that intermediate vision as well.
That's great. Okay, let's go for our colleagues here, Dr. Safwan, Usama, Dr. Yuri, Dr. Muhammad. Anyone want to ask? Yeah, Dr. Safwan, yeah, please.
So a great thanks, Dr. Ramesh. I think that because of the positive spherical aberration, that's why when you are hitting the emmetropia, you will end up with the minus 0.25 or minus 0.5. Now, the concept that we are working on here is an EDOF, and you know that all our aim is to reduce the post-op dysphotopsia. And that's why we are creating a positive or negative spherical aberration, but our limit in the manufacturer side based on the add is 1.5, because when we add more, we will end up with the dysphotopsia that we need to get rid of it. The issues is that our patients, they are required to a near vision, because most of them, they are in age of 55 up to 70 or 80. So they are using the phone. So that's the problem that we are facing with them. I'm using Physiol, iHands, and those are all EDOF. Unfortunately, Vivity, they didn't chance to use it. But all they are sharing one thing. The iHands, it provides one diopter, and at the cornea is 0.75. Your lens is what, if it is 1.25, so it will share 0.75 also on the corneal level, and Physiol it's 1.5, so 1 at the corneal level. Most of our patients, when I'm using the micro monovision, they are ended with intermediate with micro monovision, but they have difficulties in near. So that's why I found that when we are using a pure EDOF, patient still required for a glasses for near, and they are not willing to add any penny, which is, there is an extra charges. They don't need to add these charges when near is not provided for them. That's why I'm more fun with the EDOF hybrid, which is EDOF refractive. Now, EDOF refractive, it give me what I need, but without post-op dysphotopsia. I don't know whether you have any experience with it. So that's why all the lenses that came with any pure EDOF, it will show the same experience that those patients have it. They don't have the ability to read.
Yeah. The EDOF refractive you're talking about is the Triumph lens, is it? Is that what you mean?
Which lens, sorry?
The Physiol Triumph.
No.
Is that
I'm
the one you
talking
mean?
about Lucidus.
Okay. No, yeah. I've got to say I have no experience with that lens. But
because it provides 3 diopter at the lens base, so 2.5 diopter at the cornea. So it gives a good reading, reasonable, with micro monovision. The patient is very happy, and they don't have the post-op dysphotopsia.
So, I mean, I agree with you that actually there's no one lens that's going to keep all patients happy.
Yeah, exactly.
And you know, when I say the EMV is a good lens, it's not for everybody. And I still actually am using more Physiol trifocal lenses than any other total lens, because you're right that most patients really want to be glasses independent totally. Okay. But it all comes down to that first, the consultation you have with the patient and the discussion in clinic before you start any surgery, really, and what their needs are. Yeah. And for some patients who, they are better suited to a lens that doesn't give them any halos or glare, and that sort of is something they consider a major issue for them. Yeah. And they're less bothered by occasionally needing to use some over-the-counter readers for small print. So it's really patient, as with all of these things, whether you're lasering someone or you're doing a lens implant, it's really down to patient selection, and trying to work out at those first consultations, what's their lifestyle, what's their personality like, and, are they going to be happy with what you're doing for them? So, coming back to the thing about you saying, the patient doesn't want to pay extra for the lens. I can't remember how things work in terms of insurance in the Middle East, but can you hear me or?
Yes, well, go ahead. Yeah, go ahead, please.
Yeah, I mean, here,
no, the insurance, no. The net is not good with him.
Yeah, okay. Maybe
so let me just comment one thing, Mohammed. Just let me finish the story. Is that when we are talking about cost, because there is a cost, it's the Physiol and iHands, maybe iHands the cheaper one, and the Vivity now, and Rayner. For those that they have a pure EDOF, there is an extra cost, and the insurance will not pay the extra cost, because most of our tariff depend on a package, and this package, if we will break it, then the doctor will, or the surgeon will be pay for that. So when we are informing the patient that he will have an intermediate vision, and he need to pay, for example, the physio 1,000 dirham, which means around $250 extra, and for Vivity he need to pay $700 extra, and for I don't know, Rayner, what's the price. So all these are extra charges. The insurance will not cover it in our
Okay, we are
they are covering
Safwan,
the
I think.
standard that included in the package that we did it as a private. Yeah.
Okay.
Okay,
I
done.
think Safwan, okay, if we can move, Dr. Ramesh is with us here, Dr. Usama, Dr. Muhammad, Dr. Yuri. We need only very fast, please, if you don't mind, because we
Dr.
already
Ramesh,
crossed the time. Yes.
Thank you very much. It's just what's the patient shouldn't use it for this lens? Which patient criteria, guideline for other people,
Yes.
other than trifocal, which one you shouldn't use this lens for? Which patient? Like dry eye, diabetic, previous laser. Is there any concern for these patients? Or you can use it?
I just treat it like a monofocal, actually. I mean, I'd use it in any patient that is having cataract surgery who's unsuitable for a sort of diffractive type of lens implant, because the performance is like a monofocal. So
even someone had previous laser surgery, for example, we had
I mean,
collaboration also. So
in the previous laser patients, actually, in the last year or so, I've been using more of these in Vivity lenses than I have, and I'm slightly more. I've gone off using trifocal lenses in previous laser patients.
And
Okay.
dry eye, does it affect the
I
quality?
have a small question about the pupil dependency. Just we know that the small pupil and negative spherical aberration improve deep of focus. So that the patient with this lens can read in a dim condition, or we need the bright light. How you check the mesopic and photopic light condition, the difference for reading? I mean, not for distance for sure.
I've got to be honest and tell you, we haven't tested that. And, we haven't probably operated on enough patients to tell you more nuanced data about that, and haven't formally tested them in different light conditions. We haven't. All we've done really is looked at our retrospective data and tried to present that to you.
For the future, I think this is an interesting topic to study as well.
Yeah, for sure.
But Dr. Yuri, one comment is that here we can add, if the lens is decentered for those hybrid, the only issues that the patient will lose is the intermediate vision. So your talk is right. And when we are going back to the instructions of the company, they are saying that you can implant, and it's not depending, it's not pupil depending, or it's not a visual axis depending. But actually, when I start using the physio, I start using it in an excessive way, the physio EDOF, I found that any decentration, the patient will lose the intermediate vision. So it's still depending to the visual axis, which sometimes related to the pupil. And so your talk is right. In our country, those that they have very small, especially daylight, they have a difficulties in distance vision. And because the pupil is very constricted, and it's force the vision through the spherical abrasion site.
Yeah,
it's very strange because the lifestyle in this country is a nighttime lifestyle. So
the
most
night
of the
is
people
the
are
pupil is
active at
very large
nighttime.
here. Yeah.
Okay, and if this lens decentered, the coma is growing, and coma also improves depth of focus. So
that coma is depend. Which coma? According to the site and the way of the decentration. If the coma is vertical, yes. If the decentration is vertical, yes, exactly. It will help. But if it is horizontal, no, it will not help.
Well, I have a question about the stereoscopic.
Okay, yes, Dr. Muhammad.
Yeah, stereoscopic vision, 3D vision. Because I myself use the monovision in the clinic. I just put contact lens for the non-dominant eye for reading. And it helps me, actually. It's not that much fun, but it helps me look younger. And it helps me like putting the drops without having the fog from the mask and everything. But in some tasks, the other tasks, like when I was playing tennis, for example, I was missing some balls. Not because I'm a good pro player, but because I missed the ball. I don't know the depth of perception, the perception depth. most of, maybe in the microscope, I can just manage putting the eyepiece for me. But I think in the other, for the other people, the 3D, like really pilots driving maybe, something like that, is the stereoscopic vision will be affected by this monovision, like the monovision contact lens?
It may well be. Again, I can't really report back to you that we had any complaints about that. But you know, our patient number is quite small. You know, the more you do of these things, the more the kind of detail comes out in you know, problems that you encounter. So in the patients we've done, maybe they just didn't have the kind of hobbies or occupations that required you know, such great stereoscopic vision or notice that, but it wasn't an issue that came up in any of the patients' feedback.
Dr. Muhammad,
how many patients until now you have done since?
Well, the data I've shown you is really only for about 50 patients, but you know, we've gone up to about 200 now, and the ones at least I've operated on have, you know, you tend to remember the patients who cause problems. And I have essentially discharged them, you know, whereas I have got patients on the go who are having problems with other lenses. So, you know, they tend to stick in your memory if there's a problem case going on. But so far, you know, it seems to be reasonably forgiving.
Thank you, Dr. Ramesh. I think we already crossed the time more than what it expected. So maybe if we have any other question, we can keep it to the end of this session. So now we can move to our Dr. Yuri. He will give us a talk. And Dr. Yuri is well known, is an MD professor of ophthalmology department at Bavov State Medical University in St. Petersburg in Russia. Dr. Yuri, he is going to talk about the effect of intraocular pressure on the hemodynamics of the eye during phaco. Dr. Yuri. If you don't mind, all our speaker can mute themselves, please. Yes, Dr. Yuri, can go ahead.
Yeah, okay, thank you. So my presentation will discuss the effect of intraocular pressure elevation during the surgery for hemodynamics of the eye. And we know that during the surgery, the basic principle, this is the balance between irrigation and aspiration, and the normotomy, like a goal, is a golden standard. But in real life, we have not normotomy during the surgery. All the system of the irrigating the eye during the procedure can increase the intraocular pressure. Very sharp increasing can reduce the blood flow velocity. So we check the literature, and the intraocular pressure dynamically changed during the phaco procedure, during the hydrodissection and during the nuclear chopping. For example, you can see the fluctuation of the intraocular pressure during the procedure, and time to time the intraocular pressure achieve a very, very high level, above the 60, 70 or 80 or more. So today we have a new machine, which is we can put the intraocular pressure like parameters with the machine automatically try to keep during the whole procedure. So this topic is very important today for the discussion. And if we try to calculate theoretically intraocular pressure, and this pressure can be represented at the pressure of the high of the liquid column will be considered with a special formula. And we easily to calculate that if the 75 millimeter of mercury, we achieve the intraocular pressure if the bottle height is 1 meter and 5 centimeters, which is a very, very often during the surgery. Many surgeons use these parameters during the procedure. So we try to have a model with the Starlink resistor, and it consisted of the elastic fluid filled collapsed tube inside the chamber. And using the standard digital model, we can calculate the theoretical intraocular pressure, slowing down the blood flow velocity until it stopped completely. And we did a study, and we tried to check during the surgery the blood flow velocity in central retina artery and short ciliary arteries. And the aim of our study was to assess the level of the intraocular pressure during the procedure and the rate of blood flow in the vessels. So this study was included 29 cataract patients without any vascular condition disorders, mean age 72 years old, all as a cataract surgery made by the Centurion Vision System with a preset intraocular pressure level 60 millimeter of mercury. So the blood flow velocities in the central retina artery we checked, the central retina vein, the short posterior ciliary arteries was measured with the color Doppler imaging system. We use General Electric Logic SA. So we did 3 times before surgery with a normotomy, during the surgery when the pressure was elevated, and immediately after surgery when the intraocular pressure level was normalized. Every imaging was accompanied by the brachial blood pressure control and intraocular pressure measurements. We use IK protonometer during the surgery. This is our parameters of the machine. So we use the vacuum approximately 650 millimeter of mercury, torsion ultrasound, and the flow rate 27 cubic centimeter. And the IOP level was 60 millimeter of mercury. We put the sensor of the color Doppler imaging. So we have an image of the blood flow velocity in the different levels and the result. For sure, during the elevation in central retinal vein, there is no big difference. But the retinal artery, short ciliary arteries, and the central retinal arteries, it was dramatically decreasing the blood flow velocity. 30% of the patient in our study, we can't recognize the flow velocity in the stage of the diastolic stage. So it was stopped completely. And this is the slide which we look in the preoperative, intraoperative, and postoperative measuring the pressure. So the intraocular pressure before surgery was between 18 and 22, 21 millimeter. During the procedure, it was about 50, 58, 60, and postoperative 22. So the systolic blood pressure you can see was approximately 150, and the diastolic blood pressure was approximately 80 millimeter of mercury. So this is the graph for blood flow velocity for central retinal artery with a different stage of the study. So the blue, this is the systolic in central retina, and green is the diastolic, and the red is the diastolic, and the green in the vein. Preoperative, intraoperative, and postoperative. And you can see during the surgery, during the intraoperative stage, it's dramatically going down. So it was noted that with the increasing of intraocular pressure during the procedure, the blood flow velocity sharply decreased until there was no registration of the final blood flow velocity. So in our study, 31% of the cases was like that. In postoperative, immediately after they normalized the pressure, we observed almost complete restoration of the blood flow velocity compared with the initial data. So this is the dependence of the blood flow velocity in the level of intraocular pressure, the preoperative, intraoperative, and postoperative. You can see the systolic and diastolic. This is the more dependence in diastolic state. This graph shows the blood flow velocity in the lateral and medial short ciliary arteries, also in this stage of the study. Before you open the eye, during the procedure, and the end of the surgery. You can see during the procedure, the flow velocity is going down. So dependency of the blood flow velocity and the level of the intraocular pressure shown on this graph. The same picture what we have with the lateral, medial, short ciliary arteries, the same parameters. So for the summary, the result shown that intraocular pressure increased during the procedure and have a big influence for the flow velocity. The intraocular pressure level during the surgery should not exceed a certain threshold level, which is our study was 40-45 millimeter of mercury. Above this step, when we reach 50, 55, 60 or above, we have a significant changes in blood flow parameters in central retinal artery and short ciliary arteries, lateral and medial. So there is no so big influence for the then low velocity, but big influence for the artery blood flow velocity. The question of the optimal safe level of intraocular pressure during the cataract surgery is still under the discussion, but it should be below the 40 and 45 millimeter of mercury. Today, most of the machine what we have, they don't allow us to put so low parameters of the irrigation and to keep the stability of the anterior chamber at the same time. So we should to have a special system how to recognize the changes during the procedure with intraocular pressure, and the time of the machine responding for this change should be very, very small time. Today we have a Alcon technology with the active fluidic system, and today we have a new machine with the Sophie. It's a Swiss innovation technology. I want to introduce this machine during this presentation as well, because we also achieved that the 40 millimeter of mercury with this machine have induced a very stable anterior chamber, allow the reduce this negative effect of intraocular pressure elevation during the surgery. So this machine have a 3 pump and special sensor in the cassette to control the intraocular pressure during the procedure, and IP control pump with the active fluid. You can change the speed of the pump, increasing or decreasing in flow during the procedure. So the standard Sophie IP control pump integrate to the cassette, and the response is very, very fast. So this is the diagram how it works. So we have a IOP control pump and we have a sensor in the cassette. So when the pressure during the surgery increase, the pump stop or slowly moving. When the intraocular pressure decreasing, the pump slowly faster and the irrigation growing. So, and they keep the balance during the procedure very, very well. So the main advantage of the control of irrigation today is very important. And I'm sure that in the near future, it will be a new standard for the most of the phaco machine. So this is my study, and we are ready for discussion.
Thank you very much, Dr. Yuri, for this excellent presentation. If there is any question for Dr. Yuri from our panelists here.
Yeah, I just want to ask the implication of the increase on the intraocular pressure or the decrease of the ocular flow. Do you have any patient that had a permanent vision loss, light vision, or permanent or compromised vision, possibly even if you're using the IOP in the Centurion machine with 100 even? Did you have any patient who had loss of due to retinal vein occlusion, retinal arch occlusion, something like that?
So the question is, that nowadays, if you are asking the surgeon, even experienced surgeon, what IOP level do you use routinely during the procedure? Most of them, they put 55, 60 millimeter of mercury and above. So very low number of the surgeons go with the intraocular pressure level 40 and below 40 on the soft eye. So most of the surgeons, they prefer to have a rigid eye, and it's not safety. We just try to message for the community that the upper level of the intraocular pressure today, this is from the patient side. We have not the scientific data. Is it safety, yes or no? So with our study just shown that it's not safety. So the main idea how to stabilize the anterior chamber during the procedure with a low intraocular pressure and with some technology, but it's available on the market today, we can reach 20 millimeter of mercury of intraocular pressure, 25, 30, 40, with a very stable anterior chamber, which is without any risk to break the mechanism of the compensation. What we have a acute elevation of the intraocular pressure, so we have a special mechanism how to compensate from the blood velocity. So the main idea how to change the mind of the surgeons to use the lower intraocular pressure during the procedure. This is the point of the study.
Second question is, the phaco time, usually when you're doing phaco, like it takes less than 3-4 minutes, 5 minutes maximum. And then the irrigation aspirations takes like 3 or 4 minutes again to clear the cortex. And the sensor is attached to the head, to the handpiece. So during the other 3 or 4 minutes, the irrigation aspiration doesn't have this sensor.
Yeah, right.
So I think they should attach the sensor to the machine itself rather than to the handpiece. So to get really.
Yeah, I understand. But if you put the same parameters for irrigation aspiration as ultrasound parameters, you have the same fluidics. So if you put the sensor to the handpiece, the time for response is decreasing, and it's the response time is very important to stabilize the chamber. For sure, you can put the sensor to the cassette, you can put the sensor to the handpiece, but the time of the responses will be different in this. I want to focus in that even 2 minutes or 3 minutes step for chopping or for irrigation aspiration can dramatically change the light sensitivity, because some patients, if you are very, very high with the bottle, they just said, "Oh, doctor, the light is disappeared." So they can't recognize the light from the microscope. So it means not diastolic, but on the systolic step was blocked. And it's not safety for sure, even if it's short time.
Okay.
Dr. Mohammed,
Okay.
in the current machine that we are using, there is a sensor in the cassette. So Dr. Mohammed Ali, what he mentioned that when you are adding the 2 sensors in the phaco tip and sensor on the cassette, the advantage is that when you are doing the phaco, the immediate reactions, it will be very fast. But when you are doing IA, we will depend only on the sensor on the cassette.
Yeah, I understand the question, but the aspiration diameter for irrigation aspiration is not like an ultrasound tube. The fluctuation of the chamber is not the same. So you have to stabilize the chamber with the same parameters what you use during the ultrasound. You can keep the flow rate the same vacuum, but the aspiration, the aspiration volume will be less, because the diameter of the aspiration port is 0.2, it's not 0.9.
That's right. You are right. Now the pressure that I'm using is 30, but I was using 70 when I was using the bottle height. But when I use the active fluidics, now I'm happy with the 30. And back to the question of Dr. Muhammad Ali, he said that there is any parameter that we can assess the unsafety, for example, now some doctors still they are using the bottle height on 100. Is there any special parameter that we can assess the non-safety side?
Yes, we can calculate that if we put the bottle 100 or 1 meter, 5-10 centimeters, so the intraocular pressure above 70.
Yeah.
So our study shown that if we have a 55 millimeter of mercury IOP, 30% of our patients have a problem with the blood flow velocity, which stop completely. Above 60, above 70, this percentage growing. It's not 30%, it's a 50, 60, or 70% of the patients have a problem.
Yeah.
But we don't know exactly this short acute elevation of the intraocular pressure induced ischemia and yes or not. We don't know is it damage of the retina, damage other structure, yes or not. So we have an answer for this question.
Yeah.
We just fixed the problem that maybe theoretically it may be pushing the ischemia and some damage.
Yeah.
So the right way, and I'm sure that this is the right way, we should to reduce the parameter of irrigation inflow.
Yeah.
Maybe
But what happened in my country, most of the doctors, they put the same number from the gravity system, they put for intraocular pressure level. They use 100 centimeter, they put 100 millimeter of mercury. So they are not thinking. They use before 120, they put 120.
Yeah.
Which is a dangerous. This is a real danger.
It's dangerous.
We have patients that sometimes the visual recovery after postoperatively is very rapid. Just like one eye, you do him a surgery. But actually I'm not following up which IOP I used. But some patients just say my first eye, it took me like 2 hours to get better, to get vision better. But for this eye, it took me till the night to get the vision better. So is this a factor? Maybe this is a factor of assessing
maybe. Why not? Why not? We don't know exactly. So we try to study the electrophysiological study before surgery and after surgery. We try to check some response of the retina for acute elevation. Maybe for the near future we will receive some new data to have share this data with you for the near future.
Osama, you have any questions before we move forward?
No, it's very interesting. Thank you, Dr. Jory. It's very interesting. Yeah, always we don't think too much about how much maybe damaging the eye while doing surgery indirectly.
The problem was to measure in the open eye, the intraocular pressure, and measure the contact so the system. So what finally so the data what we received was surprisingly for us. We are not expect that we received the 30% of the blood flow velocity stop. So we was shocked during the study. Okay, so
I think was very interesting talk to
everyone is
about
that the soft eye is better than the hard one. So
okay,
yeah,
I think we can, yes.
we can move.
Yeah, I personally like the soft eyes, especially in high myopes. I'm doing the topical mostly. So yes, I know whenever you high eye pressure, we use the high parameters, the patient suffers. And whenever you have the lower eye pressure, the patient is more comfortable, especially high myopes, bigger myopes, something like that. So, and I think with the new technology, it's safe actually to go for the low parameters.
Yeah.
Okay. I think thank you, Dr. Yuri, for this interesting talk and nice discussions. Actually, our plan to have like a recap about our, we have done about 8 episode about cataract sessions, and we want to talk about some missing things maybe we didn't cover nicely, or we didn't cover, and some people they are having in their mind questions. The first episode for us, it was so step-by-step technique of phacoemulsification from incision to IOL implantation. Before we are having actually another talk, but it was, I think we cover it while we are talking now and discussion with Dr. Yuri about the phacoemulsification fluidics and other things. So step-by-step technique of phacoemulsification from incision to IOL implantation. We want just to highlight about certain points about this, and then we can conclude this session. Maybe in the next, other webinar, we can cover the other points. So I will ask Dr. Yuri, what are the things that if you want to highlight it or to give a hint about the incision itself while doing the incision?
Yes, yeah.
This is the question, Dr. Mohammed.
Yes.
Yeah, it's a question.
Okay, if you are not prepared, you can ask Dr. Safan till you get something in your mind. Okay, Dr. Safan.
Dr. Mohammed, the important things is that our incision should have the size, and that size will affect our results, especially for the toricity. So, in my opinion, is that for patients that they have diabetic, I'm not targeting the temporal. I'm usually targeting 12, and I have my reasons, and that's why I'm correcting accordingly the toricity that will induced by around 0.25. The shape of the incision, the entrance, usually I'm taking 45 and then 90, just to prevent the leak post-op. And important issues, in my opinion, is that when I finish the surgery, I need to search for if there's any endothelial Descemet's membrane dehiscence from the site of the incision. And I'm looking forward, definitely. I changed, I enhanced my handpiece, and my handpiece now have a stable handpiece. The phaco is balanced phaco tip, so it reduced the burning of the incisions, because that was other concern when we were doing the surgery with the old machines. So this incision site, in my opinion, is that important to have these factors in a way that prevent leaking, and considering the surgical induced astigmatism, and preventing the prolapse of the iris. So I'm not putting it in a very low, means that it's in a base of the limbus, a little bit to the cornea. So by it I can prevent the iris prolapse. That's all.
Okay, is there any comment from any other colleagues here about this point?
Just
I think
the
wound itself, sorry, yeah, go ahead.
no.
Okay, Osama.
The incision.
I think it's always is nice, sorry. They always examine before you examine the cornea well. Sometimes if there's like thinning in the limb or something, avoid that area. So don't always do the same position unless you know there's no abnormality in that area. And whatever feel comfortable with temporal superior. But if there's a stigmatism, you may think about the stigmatism correction. Are you going to do in the sleeve, or you need to have another plan? So, and surgeon can use astigmatism. Always remember that with any surgeon, he need to calculate how much astigmatism induced by his wound.
Okay, Dr. Muhammad.
Yeah, it's just the incision should be appropriate for the tip. And if you make it wider than the tip, most probably you'll have unstable anterior chamber. Second thing is, it's very unlikely that I have leak Postoperatively from the main wound, I usually have the leaks, which I have to seal it with
Stromal hydration.
side pores. Yeah, the main wound usually is not leaky. I don't know. If we have dismissed membrane, usually if it's very small, usually it retracts back. So
Yeah.
it goes back whenever you just fill the anterior chamber with BSS. So, and yes, hitting the steep axis, the corneal axis is very important. I think that's it. Temporal is much better for everybody. I think it's more easy for everybody to do the temporal incision. I think rather than the superior when you have the brows or the forehead of the patient just in the way of the probe. That's my opinion.
Dr. Yuri?
I think that Dr. Mohammed already mentioned that the steep axis is very important. So in my practice, I always try to position in the main incision on the steep axis. So time to time, this is the horizontal, time to time, this is superior, time to time for left hand, time to time for the right hand. But the result is extremely depends from the surgically induced astigmatism and preoperative astigmatism, what we have. If you are not looking for toric, for example, we have a below 1 diopters the astigmatism, or we try to ignore this small difference between steep axis and flat axis. But if it's a horizontal and you main incision superior, you increase the preoperative astigmatism induced, and you finally above 1 diopter with the clinical clinically for the patient are very sensitive. So the position of the incision, this is very, very important. Not only the 1 plane, 2 planes, or 3 planes, not only leakage. Finally, we can close the incision by the stitching if it's leakage, but the positioning is very important too.
If you move, okay, I think we already covered the incision very nicely by our colleagues here. So if we move now to the capsular axis, okay, in a different situations. So let's start with Osama. Osama, if we are having, usually what we are facing the problem most of the time in a mature cataract, white cataract.
So basically, if you're concerned about visibility, always use vision blue. There's no hesitate to use the staining. So don't start it if you don't have a good red reflexes. Better to use a stain. Always remember to fill the AC because you need that. So, and if there's anywhere that the capsular axis tend to extend outside, refill it and pull it back. And it's easy for me. It's easy with the forceps to control it down cystotome, but whatever people happy to is fine.
Okay, if there is any tics about or something, pros and cons about this one, because sometimes how you can prevent to have Argentina flag or the other one when you are dealing
on the case.
Yeah, that's you just a needle and you aspirate the relieve the pressure. So fill the AC very well and just with the needle, just puncture the center, make a small capsular axis and extend it. And at the same time, initially with the needle puncture, releasing some of the pressure.
Okay, sometimes do you prefer, Osama, to do the side port? Is there is any effect if you do the side port before you do the capsular axis, for example? Or you do only some of them, they say, I will do only the the rexis from the side port, I will do the main incision. So is there any different if you decide to
if you worry, the side port is usually depends on the angle we're using. I use a superior for the forceps, so easy for me to have the main wound. But for the aspiration, needle aspiration, then with the side port. But I think it's better to prepare the wound and paracentesis. Then you can use the side port to puncture and aspirate, then use the forceps with the main wound.
No, Osama, if we
but
are doing the main incision, if you do the main incision and then you go and do the capsular axis and finish it, then you do the side port. Is there any effect for that, or doesn't make a difference if you do the two side port, main incision and go then?
It doesn't leak. The side port doesn't leak with the viscoelastic. So you make the 2 side port and your incision with the viscoelastic, it doesn't leak from the side port.
Okay, is there any comment from others here, colleagues? Dr. Yuri?
First of all, we should recognize the problem. So before the surgery, we just have some measurements. So very important to check the size of the crystalline lens, just in the intermission case, it is increasing, and anterior chamber depth. If some asymmetrical, especially between the eyes, you can see the difference. It should be noted that maybe this is the problem of Argentinian flag is coming. The second point, you should to stabilize the anterior chamber. And the side port, one of the ideas, very good ideas, don't work to the main incision, just open it to the side port. The second, the viscoelastic, what do you use? More viscosity or dispersive one, but it is also very important. But time to time, the interlenticular pressure is so high that you try to stabilize the chamber, you try to puncture in the center, but it's still Argentinian flag is coming. So we can't control 100% the cases like that. But we try to control. So the painting is important to reduce the interlenticular pressure after you puncture the capsule. And what is very important, don't cut the capsule. You should to puncture, just go inside. But if you try to cut linear, you will see the Argentinian flag immediately.
But that and your Argentina flag does not happens in all our cases. It's only in a few cases, those cases that having the intumescent cataract. So we are concerned about the Argentina flag. Argentina flag, it's not a current complication that we are facing it in all our cases.
But it's very memorable. If it's happened.
Yeah, that's right. It's a very memorable. And we need, and always we are thinking about it when we have a white chalky cataract. So the discussion that happens is it's only a puncture and absorb the fluid. It's coming easily. All the lens matter is sometimes it will come in a way that the center it will be clear. Apart from that I need just to mention it here is the location and the centration of the capsulorhexis, because especially in a premium lens, we need to center it to the visual axis. So we have two directions: visual axis and to the limbal. That's also important, especially when we are considering a premium lens. And anti-clockwise or with the clockwise, well, I prefer anti-clockwise. I'm doing, as Dr. Yuri said, that stabilizing the anterior chamber. So I'm using dispersive and cohesive, creating what we call the soft shell. The soft shell is created by the cohesive. So I'm pushing the dispersive first and then pushing the cohesive. So it will create a dome, and that dome will enhance or stabilize the side of the capsulorhexis that I need to do it. So that's also we can add it.
And the same thing with the size. You need to have the ideal size, like 5.5.
Yes, the size also it's targeting.
Yeah.
Usually in a hard cataract, I'm targeting a larger size, especially when I'm considering that I will go to CHOP, for example. And in a soft or in a premium lens, I will try to have a smaller with 5.5, maximum 6, considering that I might need for anterior capsular capture.
Okay, Dr. Muhammad, what do you think? What is your opinion, and what is the precaution you are doing when you are doing the capsulorhexis and you are doing the measurement of the capsules? Yeah, mainly because I think most of the problem coming in the intumescent cataract, even though they are a small number, but the other one they are most of the surgeon they will not face a problem of that.
Intumescent cataract usually with these capsulorhexis forceps, it's with this capsulorhexis needed by itself. Whenever I do the puncture, I go inside the bag, and with the same needle, I just aspirate some of the white matter. So I don't waste time. And then I'm doing this spiraling. I do very small capsulorhexis and then increasing it in a spiral way. So this way I will not have this Argentinian flag, hopefully. Of course, you cannot avoid it at some time, but lately I think since like 8 years, I didn't see this Argentinian flag. So I do the spiraling. This is much better. And with this histotome, just go and aspirate some of the white matter, and then put cohesive dispersive viscoelastic. And just after that, put dispersive viscoelastic, and then complete your your capsulexis in a spiral way.
Okay. Is there
That's
any comment?
another issue. The spiral is one of the issues that we are using it when we have such a things, because it's starting with a small and enlarging. Also, it can prevent the Argentina flag.
One thing is avoid small capsulexis. If you had small capsulexis, you really that can cause problem to you.
No, actually,
No,
it's not that
Osama
much.
is not a small. It's not
If
a
you had
small.
like 3
No,
or
no,
4,
no.
then later
No,
on,
talking about general cataract. General
general.
cataract surgery in general, just try to avoid to make it smaller, because we tend to make it smaller, and that's really make our surgery more harder, you know, and could accidentally damage that anterior capsule.
It's making your surgery harder only. It makes post-op refractive instability. It's very common. So you will have surprises after 3 months, and the refractive error will shift either mostly to the plus. And I think that this is one of the matters that we need to discuss it. What's the management of the shifting of the refractive error post-op?
Okay, we have question from Dr. Hayat Khan. He is having this question: hard, letharly cataract pearls. Okay, Osama or Dr. Muhammad.
for me, okay, I just, sometimes the nucleus doesn't divide. So you just keep on dividing partially. Just go divide partially, and then the second part divide partially, and then divide partially, and so on. So you don't have to divide it all the way. And then at the end, you have 2 ways. Either the nucleus, the inner nucleus will be separated, and then you can eat it, and then this spicules can be eaten easily. Or you do have these spicules that if you can eat one, the other will come easy. So you have to, most probably, you'll have the inner nucleus separated by itself, so you can have it easy. Sometimes you are left with the plate, just eating some spicules, and then you are left with a spicule with a plate on the capsule. And this way, lately, maybe 1 or 2 years back, I'm practicing this bevel down tip. The bevel down tip can capture the plate, and then you can just with just obstructing or just making occlusion, and then you can lift it up this way. So I'm using right now in 2 cases the posterior polar, because I don't want to make dialing of the capsule of the nucleus, and for this plate situations, you just do the bevel down tip for the fit.
But it's easy, Muhammad. Just viscoelastic push a little bit to protect it. That's safer in case you
Behind
don't want to break yeah, it's just easier to put viscoelastic behind.
Well, actually, once I put the viscoelastic, and viscoelastic by itself made a complication for me. So, but with bevel down, it's much safer. It took me some time to get the courage to do it, but now I got the confidence to do it.
You got it, but it's not as safe as it sounds.
Safe.
Okay, and there's also risk to bunch.
Anyway, Dr. Muhammad, if you allow me,
yes,
just for the hard, I found that hard lens means that when we are reaching to cataracta nigra, I'm doing around 2.5 to 3 millimeter central, and I'm eating all the nucleus. Now, if I had the chance to do the hydrodissection before doing that, it's a great. But if not, then I will keep it till the end, and then I go to separate the whole nucleus to 2 halves, using that central tunnel as support to dividing this nucleus. And then
lethargy cataract.
Sorry?
The question was about lethargy cataract that doesn't separate.
Yeah, that's what I'm saying. The leathery cataract is the hardest cataract. The leathery cataract, Muhammad, is the cataract where when we are reaching to cataracta nigra. That's the stage when you have a leathery cataract, when you try to separate and you cannot separate it. So if you are going to chop this nucleus directly, you will face the leathery issues. Means that you try to separate, but you will not be able. So when I'm having this hole in the center and easily to separate using the chop one hand and the chopper in the other hand, it's easily to chop and I can handle it. Here, I can do the more hydrosection. I can rotate the whole 2/2, and then I start my chop. This will make the hardest part, which is the leathery part. The leathery content is in the hardest, the central part. It's not in the periphery. It's in the center. So when you are eating the center, you will get rid of this problem.
I think what is
Okay, I think, yes, Dr. Yuri, please go ahead.
That's a short comment. I think that the very important point, if you have a rock cataract, black-brown cataract, your parameters is very important too. So the main message, what we try to educate the young doctors, don't afraid 100% ultrasound, continuous. So never use the pulse or short burst for the rock cataract if you want to avoid the pushing the material out when you want to just destroy it. And don't afraid to reach high vacuum, 700 millimeter and above. If you're afraid with the soft nucleus, with the high vacuum, you go across the material. But with the rock cataract, there is no risk. Your holding power is increasing, and you are much more effective with the chopping if you have a high vacuum. So I suggest that the proper parameters is very important. And of course, the doctor who try to improve the skills, he never start from the black-brown cataract. He going gradually from the yellowing for the brown and black-brown. So, and he's improving his technique. All of us, we groove a little, we are chopping a little, so we mix the techniques. And if you are very comfortable with one technique, so you can continue with this. But very important to educate not only one technique, surgical technique. You should be comfortable with the different techniques. And if you have a different solution how to manage the nucleus, you will see it's very easy. There is no any problem. But if you have just only one, for example, divide and conquer technique, you are not comfortable with the chopping, and the pupil constrict, but what you can do. So the chop also is very, very important. So that is why my recommendation that stop and chop. The stop and chop is very effective. So you are groove a little and you are chopping on the same time. So you educate both techniques on the same patient. So this is my small comment.
Thank you, Dr. Yuri. There is also a question from Dr. Muhammad Jasem. He is saying, what is the advantage and disadvantage of direct chop technique? Muhammad Hisham.
Yeah, okay. For me, the phaco time is much shorter. It's very less. For the direct chop, the phaco time is much shorter, and so the endothelium has more success rate of being crystal clear later on. It depends, of course, on how are you doing it. Is it vertical or horizontal? Horizontal chop is very safe, actually. Vertical, when you have small pupil, like Dr. Yuri said, if you have very small pupil, the vertical chop is very nice. You can do it, actually. So it's if you do the stop and chop, or you do divide and conquer technique, most probably you'll have some ultrasound power for this division, and then ultrasound power of eating the fracture that you are making. So if you want to save your ultrasound power, the chop is very safe, actually. It's very efficient way.
Okay, is there any further comment about these questions from Dr. Yuri, Safwan? Yes.
As Dr. Yuri said, that there is no standard technique that we can use it. So each cataract stage having its own technique for an expert surgeon. So I think that when we have a direct chop directly, that's the lens should be intermediate hard in my opinion, and I will go directly to do the chop, whether transverse or vertical. And as Dr. Muhammad said, that the pupil size will play a role in whether vertical or horizontal. And in this way, the CHOP 100% will be better than divide and conquer, because the pupil size is small, and the hardness of the nucleus, I can hold the nucleus by the holdability effect.
Osama?
I think for me, stop and chop. That's the best technique, fit most of the cataract, but you can do different option, depends on the case. But really, stop and chop, really, whatever the cataract, you can crack it to half, soft or very hard.
Okay. There is something, is there any other comment before I think we conclude, because we can stop and we continue next time the other things related to the cataract recap about our episode. But there is something I want to say it, I don't know, I want also Dr. Yuri to comment, because we learn something from Dr. Yuri. There is something we call extracapsular cataract extractions. I mean, whenever you are having a very hard and brown, very severe, and sometimes it is still valid to do. So, Dr. Yuri.
So the question about the extra-cap cataract extraction. This is
about a very hard. If you have a very brown, hard cataract, and sometimes it's very difficult, small pupil.
Okay, so every doctor, when you are looking for the cataract, you make a solution. How to manage. And in my practice, there is no any problem if you have a rock cataract to destroy it with ultrasound. But if you have a combination, small pupil, weak zonulus, rock cataract, avitria, or high myopic patient, so time to time we are looking how to manage with a low risk. So without, and extra cap still practicing. It's very, very, very rare. But what is important, if you start the paper, how to continue, how to transfer for extra cap. There is some very important steps. First step, you should to increase the incision, and some doctors, they increase the tunnel. I think this is the mistake. So you should to cut the cornea by the normal way, forget about the tunnel. Increasing, and the size of this incision should be bigger, because the size of the nucleus depends from the size of the nucleus. And the second, never try to remove the nucleus from the rhexis. Cut the anterior capsule. It should be linear. If you want to remove the whole nucleus by extra cap manner. If the nucleus is small, for example, Morganian cataract. Morganian cataract is a very, very rough but small size. And time to time, we remove the liquid part, and we can see that the small rigid part we can remove through the small tunnel. So we use 4.5 mm, 5 mm tunnel, and you can remove the whole nucleus like extra cap. So the problem, what we expect for the near future as well, then the young doctors, we are not studying them how to manage the extra cap cataract extraction. So our generation, we start from extra cap, we know how to manage. But for the next generation, they don't know how to manage the extra cap.
Caps, yeah.
As well as intra cap or cryo extraction is nobody introduced for us. Yes. So it was for the previous generation of the surgeon. So I think that this is a mistake. We should educate the young doctors how to manage the extra cap in the difficult cases. So but the surgery is everyday practicing. If you are not practicing every day with extra cap, how you can introduce? This is the problem.
Yeah. I think that all the surgeons, the new surgeons, when they are facing any problem now, they cannot convert it to extra cap because they don't have any idea about the extra cap. I do agree fully with Dr. Yuri. So, but if you have how many times that I convert from the phaco to extra cap in my practice here, at least for the last 17 years, maybe 3 times or 4 times maximum. The extra cap was planned in 2 times, and two of them I changed to extra cap. The issues is that when I starting, I found that, well, it's definitely before doing my technique now, I found that the nucleus is a hard rock. So I cut the interior capsule from two sides and then deliver the nucleus out, just like when I was doing the envelope technique for the extra cap. I was just when I was doing the extra cap, I was just opening the capsule from the superior part around 8 millimeter, the capsule, and then which is beyond the incision, and deliver the nucleus, then removing the anterior capsule. So in the same way, I used it to develop when I change from phaco to extra cap.
Okay, thank you, Safwan. Is there
Yes,
any things, Dr. Osama, to any things before we conclude, you and Dr. Muhammad and Dr. Yuri? Then,
Yeah,
and before you start,
the
Osama,
same
give me
really. I
1
think if-
second.
problem.
Can I ask the management event to please to make the link for the certificate in the chat, so everyone can just certificate by logging through the link that will be in the chat. Yes, Osama.
So basically, yeah, if it's very hard cataract, especially corneal view not good or endothelium problem, I think is extra cap is a good option for this patient. If you haven't done it long before, maybe it's better to send it someone who do extra cap than to do start fake and you stuck with the patient, because it still is a very safe procedure and sometimes prevent patient to go to bullous keratopathy ended with another corneal graft and all this headache.
Thank you, Osama. Dr. Muhammad?
Yes, two conditions that usually I refer the ECCE is the subluxated dense cataract, subluxated brown cataract, and the endothelial count, that endothelial count is very low. Endothelial count should be done in every patient. This specular microscopy should be done in every patient, because you don't want any, you can see crystal clear lens, but actually some patients have very low endothelial count. So my advice, just do it whenever you have just like below 1,000. Maybe it's not a bad idea actually. And if you are confident with the CCE, actually the astigmatism is not that bad. If you are being trained like in India or something, you can do this small, this sutureless ECCE. They have this kind of sutureless ECCE, which actually is very nice. I tried to, I tried to learn it. I did it once or twice. But it needs actually some skills.
Okay, Dr. Yuri, please. Last comments, if you have any comment.
I totally agree that the weak zonal cases, when the risk to lose the control is one of the points for intracap cataract extraction. So we are looking the cataract grade, we are looking the zonulus, we are looking the presence of the vitreous in front, and we make a decision how to manage the case. But during the procedure, time to time, we also lose the zonulus. So if we try during the phaco procedure, if we recognize the problem, that the zonulus are so weak and we can't control the situation, we can convert not for extra cap, but for intracap cataract extraction. So usually we use the loop for this case because the anterior chamber is very deep, and in this case the nucleus is divided for 2 pieces, 3 pieces, and you should remove not the whole nucleus, but part by one. And finally, it's better to remove the whole capsule bag, because if it's still some cortex inside, and you can remove even if you finish the phaco with a 3 millimeter incision, but using the capsule hooks and other support system, you can finish the intracap cataract extraction at the end. You can remove the capsule bag if you are not looking to put the bag in the lens. For example, if you are looking at the artisan lens with the iris claw design, so we finish like intracap cataract extraction through the 3 millimeter incision. So this is depend from the surgical plan, what you are looking for. And if you are not feeling that you are keep the control till the end of the surgery, it's better to change the technique from one to the other one.
Thank you very much. I'd like to thank you all for this very nice and interesting discussions and all the points you are highlighted in our episode about the episode of cataracts that we delivered before. And we hope to meet you all in the also in another recap about the other cataracts, other parts of the cataract IOL selections, how to do, what are the techniques and different techniques that we are using for phaco and chop. There is so many things that we can also with cataract surgery in pediatric. So inshallah, we will meet again. And I would like also to ask the management, okay, they download the link. So everyone now from the participant can go, and the link is now available in the chat, so they can download. Also, I would like to invite all the who they are listening to us now, either in YouTube or in Facebook or here in the Zoom, about the third MEOM conference that will be held in 23 to 25 of September this year, 29. There will be a CME accreditation, and it is a pre-registrations. We are having a very, very interesting topics that build, and we are having more than 155 speakers. 80 of them, they are international speakers, they are from local and regional speakers. So I would like to welcome you that times. And before that, also, we are going to have another meetings, several meetings before we reach to the conference. We will have on 27, we have a glaucoma sessions. Then also in September, we have another 2 sessions before the conference. Thank you, Dr. Yuri. Thank you, Dr. Safan, Dr. Osama, Dr. Muhammad. And thanks for Dr. Ramesh. And we hope to see you, inshallah, next. And have a nice day and weekend, and good night. Bye-bye.
Right.
Bye-bye.